Hi, and welcome to the Organism Series. Today we're going to talk about Bacillus anthracis. So anthrax presents with 4 different clinical phenotypes. The first one is cutaneous. It can progress into systemic disease, but often it doesn't. But it does represent the most common form of anthrax in humans. It usually starts as a papule or a vesicle, and then it progresses into this ulcerated lesion with black eschar. It's often painless with surrounding edema, which can make it more easily identifiable compared to other skin and soft tissue infections that are painful. You don't have to have fever, but you can on occasion. So the next form is inhalation. It's an important one to know because it's frequently lethal with a mortality of up to 45%. The symptoms can start off pretty nonspecific with fever and cough, but progresses within 2 to 5 days to shock and hypotension, and about 50% of these patients progress to have meningitis. They often die from this or some of the other complications. So the next form of disease is ingestion. As the name suggests, this occurs after ingestion of the organism and often leads to GI symptoms. The most common symptoms we see are nausea, vomiting, and fever. These then progress to abdominal pain with ascites, and it can often affect the cecum and terminal ileum. The other form you can see is oropharyngeal disease, and this is associated with more upper GI symptoms. So that would be like dysphagia and necrotic ulcers. And the last form is injection. It's most often associated with anthrax-contaminated heroin injection. Moving on to the microbiology characteristics, Bacillus anthracis is an aerobic gram-positive rod. It's spore-forming, and you can see the gram-positive rods here on the picture on the right. There are other forms of the disease, including zoonotic disease, which involves contact with infected animals or byproducts of animals. It's pretty darn rare, but it can happen. The more famous version of it is the bioterrorism form. This is usually transmitted via a stable spore that infects people via inhalation, often in powdered form. The incubation period is variable, and depending on how the host gets the organism, with cutaneous ingestion, it can lead to disease in up to a week, whereas inhalation is a much wider range and can develop up to 6 weeks after exposure. Person-to-person transmission is uncommon, but it is possible. The mainstay of diagnosis is culture, although nowadays PCR is usually used. If possible, you should obtain the testing pre-treatment, but if the patient's in extremis, as they can often be, and testing isn't available easily, then you can consider treating first. There are some tests that you can get that look for a lethal toxin, especially if other modalities aren't available. It's really important to remember, though, that if the patient has central nervous system symptoms, including headache, altered mental status, then an LP should be part of the workup. Treatment is complicated and has some nuance. It's driven mostly by what form of the disease you have. So for local or uncomplicated cutaneous disease, you can get away with just a fluoroquinolone or doxy for 10 days. But if the patient has presumed inhalational disease, they get the same drugs for at least 60 days. For systemic disease, you often start with a quinolone and do at least 14 days, but the duration depends a lot on the patient's response to therapy. Once again, if you have CNS disease or concerns for it, you should make sure that you have a CNS active drug, and often should have 2. And then some helpful trivia is that Bacillus anthracis is intrinsically resistant to Bactrim. So beyond treatment with antibiotics, there's also immunoglobulin and some monoclonal antibodies that are available. Source control is also important, and if a patient has a fluid collection, drainage should be strongly considered. For patients who are exposed but don't have disease, you can consider giving post-exposure prophylaxis with Cipro or Doxy and vaccine. But a patient needs to be at least 6 weeks old to receive vaccine, and if you get microbiology data back, you can switch that prophylaxis to amoxicillin. I know that was a lot for this one, but it's an important organism and not one that we talk about often. So that wraps up Bacillus anthracis. Check out the rest of the Organism series on the Simon Says ID channel.